Hey guys, it's Dr. May. Thanks for joining me today. It's been a couple months since I did a video. This video series is a little different from some of the topics I've done so far. So recently, where I work, there was somebody who has the condition of psychogenic non-epileptic seizures. And we wanted to learn more about it so that we could better help this patient. So I volunteered to do a lot of research on it. So I did a whole lot of reading and video watching and conference attending and just trying to build my understanding, and then took that information and made a presentation and presented it to the faculty at my hospital. So I am taking this information, elaborating it even further, and making a few videos to share with you. Because PNES is a condition that's not really well understood, I wanted to add to the information that's available out there in order to best help other folks out there in the world. So this is my presentation. So I'm going to share my screen with you, and we'll get into the first part. So I'm going to call this one Understanding Psychogenic Non-Epileptic Seizures, or PNES. And the focus of this first part is going to be what I'll call seizure imitators, causes, and co-occurring or comorbid conditions. Okay, so in the total presentation of the three parts of I'm going to do, all these things are going to be covered, but today I'm going to cover the first three. So what is PNES? We're going to go over that. We're going to go over the seizures and the conditions that imitate them, and the causes and comorbidities. So morbid sounds kind of like death, but I just don't want it to be a confusing term to folks out there. It just means like conditions that kind of tend to go along with PNES. Okay, so let's just define this just to get started, so we're all on the same page. So PNES, so these seizure events, like what are they? So I broke it down into a few different lines just so we could try to digest it a little bit better. So it's a type of functional neurologic disorder, or FND. And I'm going to explain the next slide what that is. So just hold your thoughts about that for a second. It's paroxysmal. I want to use that word on the script spelling bee. It's or sudden or involuntary. That's basically what that means, that it just comes on in an involuntary way, that I didn't do it on purpose. It just kind of came over me. It's time limited. So it might feel scary while it's happening, but it does end. It kind of starts and stops. There are alterations in behavior, motor, with more movement, and sensory symptoms. And we'll elaborate on that a little bit more later as well. And this can occur with or without alterations in the level of consciousness. So sometimes you might have some awareness, and other times you might not be aware at all. Or you might be aware but not aware, kind of like that hazy kind of state. It depends on the person, and it depends on the episode. And they look like or mimic an epileptic seizure, so it's easy to mistake them without a full assessment, of course, but they don't have the abnormal brain cell firing. So it doesn't have the same kind of EEG changes, which measure the electrical activity in the brain, as would a normal, typical epileptic seizure. So therefore, it's non-epileptic. So it can look from the surface as a seizure. Even professionals might be confused by it until further testing is done, but it's not physiologically exactly the same. It still could create problems in your life. It could still feel very real. The symptoms are very real, but it's just the mechanism is a little bit different. Okay, so I wanted to just define a few terms because I did mention the term functional neurological disorder. So what does that mean, and what's the difference between that and conversion disorder? Okay, so both disorders refer to when people have problems with their sensory or motor functioning, but there's no clear underlying neurological disease or medical condition that's causing it. So it's a true problem with your sensory motor functioning, but there's not the medical cause as the major underlying thing that could be identified anyway. So conversion disorder is an old term. It's from Sigmund Freud from the 1800s. So it's old. And basically it means like your psychological problems or traumas or stress are being converted into a physical problem. So the mechanism is implied that the psychological becomes a physical. It's like being expressed as a physical. But the trouble is with PNES and some other functional neurological disorders. So PNES is a type of functional neurological disorder, but there's other functional neurological disorders. So for some people, they can't identify any major issue or any kind of mental illness or any depression or any trauma. So in order to make it diagnosable so that the doctors could bill for it and treat it, they renamed conversion disorder as functional neurological disorder. So the criteria that doesn't require there being like an underlying mental illness or trauma, but the outcome or the presentation is still the same, that there's no underlying neurological disease or or medical problem creating these sensory or motor symptoms. So we don't know why it's happening, but this is happening. So therefore we could diagnose with functional neurological disorder. Okay, hope that makes sense. Okay, so I want to cover two other important terms here too, just to clarify. So psychogenic. So if we break down that word, psycho doesn't mean you're psycho, okay? It just means that there's a psychological, and genic is origin. So it's a psychological origin that we're assuming is creating this physical issue. So it's real physical symptoms, and you can't directly control them. But they're assuming that there's some kind of mechanism that's more psychological in nature. And it doesn't mean you're crazy. And it doesn't mean, there's something wrong with you and like, a bad way. It's just, and that happens to us in all different kinds of ways. Ever get a stomach ache when you're nervous? Or some people like have an anger problem and then they get a heart attack. Or other people have back pain and they can't see anything on the x-ray, but it's real back pain, but it's fueled by anxiety and anger, for example. So this happens in all different areas of our physiology, and there's a strong mind-body connection for everybody. But for some people, the connection happens to be that my psychology is creating a seizure or something that looks like a seizure. So it's still, the pathway is the similar kind of thing with the mind-body. It's just the presentation might be a little bit unusual. Okay, but that's basically what it means. That the origin of this seizure-like activity might be more psychological or stress-based or trauma-based in nature. Okay, so the next term is malingering. And sometimes people falsely assume that if you have a PNES diagnosis or, seizures that don't have an EEG change on, on the test, that you're faking it. But people with PNES are not faking it. There might be a very small subset of people, they say, that go to epilepsy centers claiming they have seizures and they are faking it, but they said it's a very small percentage. So people with PNES are not among the people that are malingering. So what does malingering actually mean? Malingering, if you define it, means a falsification or profound exaggeration of illness, physical or mental, to gain external benefits. So if you look at the picture I put here, it's kind of like if you're a kid and you really want to not go to school today because you're sick, your teacher, you want to avoid some kids you don't like, you don't want to take the test, you might fake being sick. Mom, I don't really feel good today. Because you're trying to get out of something. You're trying to get a certain benefit from looking like you're sick. But this is not what's going on with PNES. People are not throwing themselves on the floor, looking around and shaking on purpose because they're trying to get out of something. Okay, there might be certain effects that come along with having that problem, but it's not done consciously and on purpose. Okay, so it's malingering is volitional. You could start and stop it at will, but psychogenic is not. Okay, so this is a psychogenic non-epileptic seizure. Okay, so what's in a name? So PNES is currently considered the most acceptable name for this condition, especially in the United States. In the United Kingdom, they tend to call it non-epileptic attack disorder, or NEAD. So those two are probably the most acceptable names. But over the years, other names have been thrown out there. So you might have heard of other ones along the way. So sometimes they've been called functional seizures because it's a functional neurologic disorder, as I mentioned earlier. They can be called conversion disorder seizures for the same reason. Other names might be dissociative seizures because there's a correlation with dissociation. So dissociation can mean like there's a disconnect between my consciousness and what's going on in my body. So my body's doing something that's outside of my awareness that I'm not really syncing up with and that I'm not fully present while it's happening. So there's a dissociative component. There is a part of myself that's activating this event. So there's some dissociation associated with it, at least for some people. So that's why they might call it dissociative seizures. A more pejorative name, which is an older name, is hysterical seizures. So the term hysterical is like an old term as well, like in psychology. So before they had other more modern names for things, people who were very emotional, especially women, were called hysterical. So calling it a hysterical seizure is kind of insulting a lot of the time. So I would not use that term. And I'm sure if you're the one with the seizure or the PNES issue, you don't like that term either, my best guess. Pseudo seizures. This is actually still used quite a bit. I've heard doctors and other professionals recently using that term, even though it's not an official term anymore. It's an old term, and it's kind of insulting. Pseudo really means fake. So when you're saying to someone, you have a pseudo seizure, you're kind of telling them like you're faking it. And they're not faking it because, like I just discussed, it's not a malingering problem. It's a psychogenic problem. So just because there's no EEG changes, it doesn't mean the person is faking it. So please avoid that term. All right, so why is learning about PNES important? So people with PNES are often misdiagnosed and misunderstood. And I'm going to go over some of the seizures and things that imitate seizures so you can see how complex it is to diagnose this and how easy it is to misdiagnose. So it makes sense that it is misdiagnosed a lot because it's not always understood or studied properly, or the procedures for diagnosing it aren't done properly. It's misunderstood a lot of times because people do think that people are faking it and that they do have control, whereas maybe they don't have control. And a lot of people have gone through the ringer, not just because of the seizures themselves, but because of the way professionals and friends and family have reacted to their seizures. So a lot of people report feeling invalidated, disrespected, shamed, poorly treated by others. That, people are constantly saying, why are you doing this? Knock it off, get up, stop this, you're faking it. You just, why you have to do this, you're just trying to get attention and all that kind of stuff. And it just compounds the problem. It makes people more stressed out, more isolated, and that just fuels the issue even more. Another issue is that professionals often don't know what to do. So they get shuffled from provider to provider. So a neurologist, for example, might say, you know what, you have PNES, we figured this out, but this is more of a psychological issue, so you need to go see a psychologist. Then the psychologist will start seeing the person and say, well, this is freaking me out. Like, you're having these seizures. I'm not really sure if this is really completely psychological. I'm not sure if I'm comfortable treating this. You better go back to a neurologist. And the neurologist says, oh, yeah, but I can't give you medication for this. This is not really a neurological problem. You got to go back to see a therapist. So people are shuffled around, and meanwhile, they're not getting any in-depth treatment anywhere they go, or any meaningful treatment. And that just delays recovery and puts people's life on hold. So it's really creates a lot of suffering. So if you understand PNES and you can make a good differential diagnosis and you can get the proper kind of treatment, you have a much better chance of recovery. And recovery is possible. And there are treatment protocols that have been developed in order to help recovery. And I'm going to talk about that more in one of the future videos. Okay, so that's why. All right, so bringing us to the next video, which I hope, next slide rather, which I hope puts a little smile on your face, is going to start off the next section of this video called seizures and the conditions that imitate them. So just like there's a real Elvis, and then there's a bunch of Elvis imitators, there's, actual seizures with the EEG changes, and then there's a bunch of conditions that people can have that look like seizures, but they're not actually seizures. So let's talk about all these different possibilities just to kind of normalize how complex this can be and how important it is to get a good, thorough assessment. So we'll start with the original thing, like the original Elvis, okay? So what's a seizure? Seizure is defined as a burst of uncontrolled electrical activity between brain cells that cause temporary abnormalities in muscle tone or movements, such as stiffness, twitching, or limpness, behaviors, sensations, or consciousness, which is like your state of awareness. So the type of seizure, there's different types of seizures depending on which areas of your brain are affected. So with the little graphics on the left, you can see there's generalized seizures. So those are seizures that could affect the entire brain. So there's a lot of electrical activity. Other seizures are more focal, so it involves a smaller area of the brain, and those could have a different presentation. So a whole brain seizure could be like a grand mal seizure, they say, which is a tonic-clonic seizure. So the tonic is like muscle stiffening, and the clonic is more of the shaking. And a motor control area seizure, which is more of a focal seizure, can involve twitching. A visual area seizure, maybe in the occipital lobe, you might see things like lights or auras or visual hallucinations. A temporal lobe seizure, which is more on the side of your brain, could create fumbling, confusion, loss of memory, or what they call automatisms, which are like kind of robot-like behaviors. So these could present all different ways, but they're all considered seizures because there's a burst of uncontrolled electrical activity in the brain, like there's an electrical storm in the brain. And interestingly, a fun fact is that every brain has the potential to seize. So under the right conditions, anybody could have a seizure. And in fact, they say about at least 5% of the population have had a seizure in their lifetime. And if you count like the febrile seizures, like the seizures that little children might get while they have a high fever, it could go up to 10% of the population. So that's like a true EEG change seizure. So what's epilepsy? So epilepsy is when there's spontaneously recurring seizures. So sometimes a person might have a single seizure because of a certain event, and that's the end of it. They have one seizure and it's not recurring. It's not becoming a condition. But if it does recur and it happens over time, several times, now they could call it epilepsy. So triggers for epilepsy, they actually say stress is the #1 triggering factor. So even with epilepsy, where this true EEG changes and it's a real seizure, stress in the mind-body connection is still operating. Other triggers can include missing sleep, missing medications. So if you're taking anti-seizure medications and you miss your medications, it could trigger that. Or maybe even getting off things like benzodiazepines too quickly to create a seizure, so like a withdrawal, physical illness, certain sugars or in dietary indiscretions or alcohol. So even, if you have too much sugar and stuff like that, it could screw things up and create a seizure. So EEG, so getting back to that. So that's even not completely clear cut in all cases here. So there's often abnormal EEG spikes during an epileptic event, which we would expect to see. But they say that EEG could be present as normal in 50% of people. So even that's not completely clear cut. They said to measure the seizure activity, you need like about a golf ball size area of your brain that's seizing to register. So if it happens to be deep in your brain or small, it may not even register as a seizure when you're getting the EEG. It might be harder to detect and more tests might be needed. Another thing is that even if you have epilepsy, they would expect that your brain activity between seizures would be normal. But in 50% of the people, they actually have spikes in between seizures. So that makes things a little more confusing as well. So treatment. So generally speaking, you would prescribe anti-seizure medications or anti-epileptic drugs or AEDs to treat epilepsy. And a lot of people do respond to them and it does help prevent the seizures. But, 30 or 40% people don't respond to those drugs. So sometimes they'll say, well, PNES, you could tell it's PNES because they're not responding to anti-epileptic drugs. But with real epilepsy, some people don't respond to that either. So it's not always a clear-cut problem or way of telling the difference. Okay, so here's some medical imitations of seizures. I saw this referred to as physiologic non-epileptic events, or PNEE, on the internet. I'm not sure if they use that term all the time, but there are several things that you could experience medically that could look like a seizure, but they're not actually a seizure in the epilepsy sense. So one could be sleep disorders, such as narcolepsy. So narcolepsy might be like you suddenly dropping off to sleep. Just like with a seizure, you might suddenly drop off into a seizure and kind of go temporarily unconscious. So it might look similar in some ways. Some severe migraines, especially with the visual auras and hallucinations, so to speak, and lights, might look like a certain type of seizure. Fainting or passing out, such as like a syncope, hypoglycemia and other metabolic conditions. So if your sugar's too high or too low, you might have a response that kind of looks like seizure, but it could be treated by rebalancing your blood sugar and things of that nature. In certain cases, certain vascular events such as a stroke could look like a seizure. Autoimmune encephalitis, which is another issue with your brain. Drug or alcohol withdrawal. So if you get off alcohol too quickly, and you don't have medical assistance in getting off alcohol, if you're used to drinking high volumes, a seizure could occur. Again, if you get off benzodiazepines too quickly, or if you stop certain medications too quickly, it could lead to a seizure or seizure-like activity. That's maybe not officially a seizure. It really depends. Also, certain movement disorders might look like a seizure, especially with the tonic, clonic, kind of thing. Well, tonic is the stiffening and clonic is the shaking. But if you have a movement disorder that involves shaking, it sometimes might appear like it's a seizure, but maybe it's something else. All right, so psychological imitators of seizures. In some cases, panic attacks can even look like a seizure. So there could be confused thinking because you're kind of so anxious, you're kind of lost in the fog of your anxiety. You're not fully aware of your surroundings. You feel like you have kind of like tunnel vision, you have hyperventilation. It could actually look like a focal seizure in certain cases. Nightmares and night terrors, which is different from narcolepsy, which is dropping off to sleep during the day. So at night, if in some cases, it can look like nocturnal frontal lobe epilepsy if you have certain nightmares and night terrors when you're suddenly disturbed in the middle of the night. Intermittent explosive disorder. So that could look like temporal lobe epilepsy. So this is when people kind of suddenly have an outburst of rage and anger and violence. And, sometimes it has to do with a temporal lobe epilepsy type of thing. But in other cases, it's intermittent explosive disorder. But on the surface, it could look very similar. And finally, autism spectrum disorder, especially with some of the stimming and the kind of behaviors that might, like the flapping and things like that. Maybe it looks something like certain movements that are associated with seizures, but it's really more connected to the autism. Okay, so now here we are back to PNES itself. So it's another condition that sort of imitates a seizure. So here's some facts and statistics for you, just to kind of understand this better. So they say about 0.4% of people, so about 4 in 1,000 people experience a psychogenic non-epileptic seizure. So that's about 2 million people worldwide. So given that there's billions of people worldwide, that's a relatively small percentage. And you can say, well, all right, 0.4% of people, it's really not that much. But if you think about it, it's a similar percentage of people that have multiple sclerosis and Parkinson's. And multiple sclerosis and Parkinson's are much better understood and well known and recognized by people as compared to PNES. So a lot of our resources were put into other places, and maybe there's more stigma to PNES because people think they're faking it, and so there's less attention put to it. About 20 to 40% of people who come to an epilepsy center complaining of seizures actually have PNES, so about a third of people. And about 1 out of every 4 to 5 patients who are diagnosed with pharmacoresistant epilepsy, so people who they believe have epilepsy but aren't responding to drugs, actually have PNES. So some people truly, like I mentioned earlier, have epilepsy, but the anti-epileptic drugs are not helping them well. But in some of those cases, they discover later on that, the reason why they're not responding to drugs is because it's PNES. And PNES can occur in people of all ages, but it tends to be a higher percentage in adolescents and young adults. So about 80% are 15 to 30 years old. And interestingly, 70 to 80% are women. So it might have to do with, maybe partly the way we're wired up or the way we're socialized. I'm not really completely sure why it's such a high percentage of women, but it is a higher percentage of women. And it's just found in cultures all over the world. It's not just a Western problem. Okay, so comorbid epilepsy and PNES. So that basically means some people have both conditions to make it even more confusing. So in some cases, people had true epilepsy when they were young, and that was diagnosed and medicated and treated. And then later on in their life, the epilepsy subsided, and instead, PNES non-epileptic seizures came about. So maybe your brain kind of learned about how to handle things with seizures and learned what a seizure was. And so later on, even after the epilepsy resolved, your brain learned to use that as a mechanism to express emotions, possibly, okay? Other people concurrently right now sometimes have an epileptic seizure and sometimes have a PNES event in their life or at this time. So it depends on the person, and that's why a careful assessment needs to be made. And talk more about that in the next video. And the comorbidity or the co-occurrence of epilepsy and PNES is higher in people who also have cognitive developmental delays. So in the average population, it's 10% of people have both. But if you look at people with cognitive problems, it's a higher percentage of having both. So that's important to keep in mind when you're diagnosing as well. Okay, so the next section we're going to do in this video, it's a lot of C's. I had a sale on C's, causes and co-occurring or comorbid conditions with PNES. Okay, so I want you to kind of look at this for a minute. So even though PNES does not involve EEG changes, there are brain differences in people who have PNES versus people who have epilepsy, and it's important to look at that. They're still studying it, though. It's not like a clear-cut, this is definitely different here, and this is definitely different there. There's a lot of studies, and some of them contradict each other a little bit. But they think it's partly because PNES is what they say is a pleomorphic disorder, like it could take different forms. There could be different routes of what could cause it. And it's kind of heterogeneous, I guess is another word you could use. Like it has slightly different expressions, and there's different subtypes of PNES, which we'll discuss in a future video. So that's why it's not always a clear cut, like this is definitely the difference in the brain of PNES people. But I'm going to summarize some general things that were found just so you get a flavor of it. So first thing is that they looked at structural abnormalities. So PNES brains are a little bit different structurally. So some areas are a little thicker, some areas are a little thinner or smaller. There's some differences in the white matter tract. So there's gray matter and white matter in your brain. The white matter are myelinated. I don't want to get too much into the fancy details about brain anatomy because I know this general audience is probably kind of glazing over. But just to know, like there's different differences in the way the brains are structured in PNES, the way the size of different things are. Okay. Next is what they say is metabolic abnormalities. So when they talk about metabolism in the brain, it's all about the energy flow. Where is the energy and the oxygen and the glucose and stuff flowing in the brain? Where is your body channeling the energy? So there are some differences in where PNES brains are getting their energy and which areas are energized. So they say that there's abnormalities in where the energy is being put for emotional processing and motor control. So if you think about PNES, it's created by psychological issues in a lot of cases, and it creates some motor dyscontrol as part of the problem. So it makes sense that those areas of the brain, the metabolism is different. So they're still kind of studying that. They say that they believe it's more of a network problem, though, in the brain. So network, think about a social network is like the connections between different people in your life. So it's the connections between different parts of your brain, and the way they connected and how strongly they're connected is different in people with PNES. So some studies say it's increased connectivity and directionality in the information flow from the right amygdala, which has to do with processing emotions, to your supplementary motor cortex. So it's funneling the emotions directly into the motor cortex more strongly than in the average person. So when you have strong emotions, it's getting expressed in a motor way. That's basically what they're trying to say. They also found hyperconnectivity, or like strong connectivity, between areas involving emotional processing, executive control, which means like the ability to have deliberate control over certain things, and movement. So there's some strong connections in those areas in people with PNES who also have problems with dissociation. So that's one other thing. And then finally, this hypoconnectivity, or not too much connection, or lower than average connection in areas involving emotional processing, executive control, and motor networks. So there's not a lot of coordination in those areas. So when you're feeling emotions and you're trying to have top-down control of trying to work on them or control them or manage them, and you're expressing it in your motor, those pieces are not working in a coordinated way. And so they believe that that could be creating some of the seizure-like activity. But again, they're still studying all these things. There's no really clear-cut answers for everybody. They believe it's a heterogeneous condition, so that's why there's some of these differences. But I just want you to know overall that there are differences in the brains of people with PNES. It's not just something made up. All right, so PNES and traumatic brain injury. So this is a special type of brain problem that some people with PNES might have. So they say that if you have a traumatic brain injury or TBI, your risk of developing PNES is 3 times greater than the average person. So when your brain is already, suffered an injury, you're more likely to have that PNES evolve eventually, arise. So about 50% of people with PNES have a TBI. So that's a pretty strong percentage. Half of people who have PNES have some kind of history of traumatic brain injury. They also talk about what they call a double hit phenomenon. So physical trauma to the brain, like a TBI, plus psychological trauma combined to increase the risk of PNES. So that's like the double hit, both of them operating together. And just like it would be harder to treat a psychological or psychiatric disorder when somebody has traumatic brain injury, it's also more challenging to treat people with PNES, and they tend to have more negative outcomes and more problems and issues. Not that it's impossible to treat, but it's definitely more of a challenge. So what have they found? They said that people with both conditions have more mood disorder diagnoses, major depression, behavioral impulsivity, PTSD, and trauma or abuse histories. So there's more psychological, psychiatric things going on at the same time as well. They're more likely to receive disability, so it probably implies that their functioning or ability to function their daily life is impaired, or ability to work at the very least. And they had lower global functioning. So overall, their life is a lot more difficult when both conditions are there. All right, another thing that they're studying to some degree is hormone differences in PNES, especially as compared to people with epilepsy. And again, just like with the brain differences, there's no really clear-cut, definite differences that they're positive about this time, but they're studying it and they're seeing some trends. So they're kind of seeing, yeah, there's another physiological thing that's going on that helps to differentiate people. So one of the hormones they studied is called neuropeptide Y. So that has to do with resilience for dealing with stress. So when I have neuropeptide Y at a good level, my resilience for dealing with stress is pretty good. But people with PNES tend to have a lower level of neuropeptide Y. So they're not as resilient to stress. And if you think about what I was saying earlier, psychological issues, stress and PTSD are more operating and channeling those emotions into a seizure for people with PNES. So it makes sense that if I'm not as good as managing my emotions and stress, there's a chance that this is the expression for it, the seizure activity. So that's the neuropeptide Y. There's some other studies that say neuropeptide Y plus adrenocorticotropic hormone, which also has to do with stress, that levels of these hormones predicted PNES in female patients with over 90% accuracy. So that's an interesting finding, and it's pretty high percent, Another thing that's a little bit more controversial, they talk about prolactin levels. So they say that the absence of prolactin levels after a seizure are seen more in people with PNES than in people with other types of seizures, especially generalized clonic-tonic seizures. But there are some false positives and false negatives, so they say it's not really like a perfect way of differentiating. But there are some differences that they've seen and some trends, so they kind of looked at that. And finally, I know these aren't exactly hormones, but inflammation markers. So when your body is, it's more inflammation, they're trying to fight something off, like fight off an infection or something like that. So levels of 5 inflammation markers, or proteins, were elevated acutely in people who had experienced epileptic seizures, but not in people with PNES. So if you measure the inflammation markers afterwards, you might see, an increase in them in people who just had an epileptic seizure, but not an increase in people who had a PNES event. So if they study this further, there's a chance that they might be able to do some simple blood tests to help you differentiate the conditions, but they're not at that point now, not yet, but they're still studying it. So maybe there's some hope down the road that this will be part of the diagnostic procedure. Okay, so another thing we could look at as well is arousal patterns in PNES. So in some of my other videos, especially the ones for sensory motor psychotherapy, I talked about the window of tolerance and hyperarousal and hypoarousal. So hyperarousal is when, you're feeling more hyped up, more anxious, more angry, high energy, you're preparing for fight or flight. So people with PNES tend to have more hyperarousal before a seizure. So there's some stress going on beforehand. And this could include being hypervigilant, kind of like maybe even scanning your body for, there's something wrong somatically, there's something going on in my body that doesn't feel right, because I might have an early warning sign and I might react very strongly to that. It could be something in my environment that I'm reacting to. And so my arousal before the seizure might be a little on the higher side or hyper-aroused side. But then after the seizure, or once I even said during and after the seizure, there's more hypoarousal. So it's a low arousal pattern. So they say that on an unconscious level, my body might learn that, oh, this seizure thing works. It helps you calm down. Let's do it again. So it kind of trains your body to use a seizure as a way of managing stress and calming down and feeling better if something's been going on in your life. And this is not happening consciously, but it's something your brain might start to learn. So here's a few other comorbid or possibly co-occurring physical problems. So if you have PNES, there's a good chance you might also have these physical problems. So this is what this means. So people with PNES often have pain conditions, including headaches and pain disorders such as fibromyalgia. They might suffer from chronic fatigue syndrome, sleep problems, and probably some other things that I didn't quite find or put in here. But another thing they said, which I thought was interesting, I just lumped under the slide anyway, is that sometimes PNES starts after somebody gets brain surgery, including brain surgery for epilepsy. So a new onset of PNES can occur in like around 2 to 8% of people who just had brain surgery to fix an epileptic condition. So the epilepsy might stop and the PNES might start. So it could be, again, that your brain sort of learned seizures and now is using this as a mechanism to express emotional distress. Even other brain surgery, they said, could precipitate the onset of PNES. So when a doctor is taking, your history, they should be looking at that as well. Oh, did you just have brain surgery? Maybe that had an impact and that could create something. Okay, so now let's look at some psychosocial risk factors for PNES. So these are more like things that you're exposed to in your experiences and your environment that might contribute to the onset of this disorder. So 30 to 80% of people with PNES have a history of trauma, including childhood trauma and adult trauma, history of abuse, a stressful childhood, family dysfunction, insecure attachment, and isolation. So all these kinds of things could create more stress in your body and increase your risk for PNES. Unresolved grief as well. Other societal factors that could contribute and create more stress in your life, all the things listed on the slide here in the picture. So racism, the ongoing stress of feeling discriminated against because of your race, because of your gender, your sex, being of low socioeconomic status and, struggling with poverty or food insecurity, being disabled in other ways and facing discrimination for that. All those things could compound and create the stress that precipitates PNES. Other things could be like a demanding job or pressure to succeed or other kinds of daily life stress like that. And even the stigma of PNES could perpetuate PNES. So if you had the condition and people are invalidating you all the time, saying, oh, you're faking it, and why don't you just knock it off? And, people are not treating you well because of that, the stress of that could perpetuate the PNES. And for some people, before you understand what your seizures are, what it's related to, is it epilepsy? Is it PNES? Is it some medical condition? The stress of not knowing could keep the seizures going. And sometimes for some people, which we'll discuss in one of the future videos, when they finally get told, like, you don't have epilepsy, guess what? You just have PNES. The relief of it helps the person relax, and then the seizures just spontaneously stop. That's in about a third of the cases. So even that could be a psychosocial risk factor, right? The stigma and worrying about it. Okay. So these are psychiatric comorbidities. So if you have PNES, there's a good chance you might also have some of these. The most common ones are anxiety, including panic disorder, depression, and PTSD. So those are the ones they talk about the most. They also sometimes talk about personality disorders, especially in people who have chronic PNES that's difficult to treat, because a personality disorder, such as borderline personality disorder, avoidant personality disorder, is a more chronic pattern of emotions and behaviors and relationships that could kind of keep you stuck. And so people who have a hard time healing PNES might have a personality disorder. Dissociative disorders, as I mentioned earlier, about a third of people. Then there's another thing they call alexithymia. And this is when, like, think of like a lexicon, like it has to do with words. When people experience emotions but have difficulty putting words to it or expressing it or sharing it, there's a chance that instead it could be channeled into a seizure. So that's why alexithymia is pretty common. So one of the treatments could be learning how to be mindful of and recognize and put words to your experiences so that you could deal with them in a more direct way. Other people with PNES have behavioral disturbances. So in addition to like holding in your emotions and avoiding them and suppressing them and channeling them into a seizure, you could also at the same time have issues with anger and aggression and impulse control and like acting out. So there could be a suppressing and an acting out thing going on within the same person. They say anecdotally, some people with autism spectrum disorder might have a higher rate of PNES, but they didn't really talk about research for that. Some people have substance abuse at the same time, and less commonly, some people have psychosis. And 20%, though, don't have any known psychiatric conditions at the time that they're coming for help for their seizures. So you may not have any at all, and that kind of could reflect the fact that either there isn't anything, or you have something and you weren't able to identify it, or the fact that PNES is just caused by different mechanisms, and it's not always a psychological disorder. And cognitive issues. So a lot of people with PNES report issues with cognition. So forgetfulness, difficulty with their memory, feeling distracted, difficulty finding words. They might even be so concerned about that, self-conscious about that, that they're over-interpreting any cognitive issues as being a problem and maybe seeing even more than what's there. So that's why the first paragraph said 60% report subjective cognitive symptoms. So that means like what I'm perceiving in myself subjectively. Like I believe this is my problem. So objectively means that someone gave me some tests and measured certain cognitive issues. And they say that not all the subjectively reported problems are seen in objective tests, but there are some objective deficits that were observed and measured in people with PNES. So that could be difficulty with attention. So you might have selective attention, like over focus on some things and under focus on other things. Slow information processing. So your mind might feel like it's operating a little slower than average, and distractibility. So those were measured on tests. But again, it doesn't always map up to what the person might present with, or what you might perceive in yourself. And they did find, though, that when PNES is treated well and it starts to resolve, sometimes in people, the cognitive issues also start to resolve. So that's part of the good news. Okay, so now that we've done a full medical, neurological, psychiatric, and psychological assessment, and we covered all the things I just covered, how do we then best actually make and present the diagnosis to somebody? So that's going to be the focus of my next video. So stay tuned for the next one. So I hope this was helpful, and thank you for watching, and I will see you soon. All right, take care, everybody.